So good afternoon, good evening, or good morning, wherever you are joining us from. A very, very warm welcome to you all. I'm Dr. Sohaila Chima. I am the Assistant Dean for the Institute for Population Health here at Weill Cornell Medicine-Qatar, and also an Associate Professor of Clinical Population Health Sciences. So thank you so much for joining us for today's session of the Population Health and Wellbeing series. As you may know, its objectives are we discuss contemporary critical topics which are relevant to healthcare, medicine, and population health. We examine evidence-based practices which are germane to public health and patient care, and describe opportunities and challenges in the evolving face of healthcare and population health. So just some housekeeping, your cameras and microphones have been turned off. You can use the Q&A feature to type your questions and comments. You can also post your questions in the chat feature. So if you don't want to post in the Q&A feature, please go ahead and post in the chat feature. We will be able to see them. Questions will be addressed at the end of the session, and I will be moderating the question and answer session with our speaker today. Accreditation, of course, this is an accredited activity, and it is accredited both by ACCME and by DHP, Qatar here at the Ministry of Public Health's Department of Healthcare Professions. This is an important notice which you all probably are already aware of, especially for physicians and other licensed practitioners here in the state of Qatar. So now the state of Qatar requires that you provide your Qatar ID number and MOPH license number to your CPD provider, which is us. So you will be receiving an email notification with a survey link where you can fill and submit this information. Please ensure that the email ID associated with your Cloud CME account is entered in this survey as well. So this is very important for us. Please, if you want the CME CPD credits, it's extremely important that you provide us with your correct Qatar ID number and MOPH license number. So the post-activity evaluation will be available in your Cloud CME account by March the 5th. And the healthcare practitioners which are licensed in Qatar, you will only receive your credits once we have your Qatar ID and the MOPH license number. If we do not have these two items from you, we will not be able to issue you credits. So you will receive an email notification once the evaluation is available in your Cloud CME account, and your certificates will be available for download once you complete the post-activity evaluation on the Cloud CME portal. So we have a great speaker today lined up. I'm very, very excited, and it is my honor to introduce Dr. James Lewis. He will be talking to us about nutrition as therapy, perspectives of a gastroenterologist and an epidemiologist. Dr. James Lewis, he's professor of medicine and epidemiology in the division of gastroenterology and hepatology at the University of Pennsylvania, Perelman School of Medicine. He's also a senior scholar in the Center for Clinical Epidemiology and Biostatistics, Chief of Gastroenterology at Penn Presbyterian Medical Center, Associate Director of the University of Pennsylvania's Inflammatory Bowel Disease Program, and Director of the NIH-funded T32 training grant in GI epidemiology. He serves as the Director of the Human Research Core of Penn Center for Nutrition Science and Medicine, and co-director of the P30-funded Biomedical Data Science Core in the Center for Molecular Studies of Gastrointestinal and Liver Disease. For more than 25 years, Dr. Lewis has been actively involved in clinical research related to inflammatory bowel diseases and other gastrointestinal diseases, with the goal of improving patients' outcomes by optimizing the use of medical therapies, diagnostic tests, and nutrition. His work has been funded by the NIH, AHRQ, PCORI, CDC, and numerous other foundations and corporate sponsors. He's currently the lead scientist for the Crohn's and Colitis Foundation's Inflammatory Bowel Disease Plexus Research Program. Dr. Lewis, a very, very warm welcome to you. We're excited to have you with us, and over to you.
Thank you so much for the welcome. Let me just share my screen. And just confirm that it's sharing correctly.
It is sharing correctly.
Wonderful. Well, thank you, first of all, for the opportunity to come back virtually and to share in this incredible program. As we were speaking beforehand, I was really amazed at the wonderful program that you put together and the outreach that you have. And so for me, it's an incredible honor to just be able to be part of this. And hopefully in the course of the next 45 minutes or so, I'll be able to present to you a picture of how I see nutrition, both at a very sort of general level, and then towards the end, coning down a bit in the space where I work most closely. In terms of potential conflicts of interest, I'm going to not really be discussing anything unlabeled or unapproved in terms of drugs or products today. This is about nutrition, and of my various potential conflicts of interest, probably only some research funding from Nestle Health Science would be particularly relevant to today. You know, food is a good thing, and most of us really love to eat. None of us could survive without food and nutrition, but we do have some challenges with it, and these typically fall into one of four big buckets: either too little access to food, too much food that we're consuming foods at the wrong time, or consuming the wrong types of foods. I'm going to start on the side of too little and ask you to think briefly about malnutrition. Malnutrition is defined as inadequate intake of energy and/or protein over a period of time that results in weight loss, lean body mass loss, loss of fat stores, and diminished functionality. There's three general ways that people become malnourished. One is through starvation, which is sort of obvious, just inadequate intake of nutrition. But there's also chronic disease-related malnutrition, which is exacerbated by inflammation, and then acute disease or injury-related malnutrition. In 2016, the Global Leadership Initiative on Malnutrition brought together representatives from a number of different organizations from around the world with a goal to create a minimum set of malnutrition diagnostic criteria that would be endorsed and used globally. It's actually quite simple. It's a two-step model in which you would have risk screening, and those who screen at high risk would then undergo a diagnosis assessment to grade their severity. And the malnutrition diagnosis was based on having at least one phenotypic and one etiologic criteria present. And then you could use the phenotypic criteria to stage severity. And this is really quite simple. The phenotypic criteria focus on weight loss, such as 5% in less than 6 months, 10% in more than 6 months, having a low BMI, or having reduced muscle mass. And the etiologic criteria are reduced nutritional intake, so less than 50% of your requirements for more than a week, or any reduction for more than 2 weeks, or in the case of where I work, chronic gastrointestinal disorders with adverse nutritional impacts. And then there's also an etiologic criteria for inflammation. It turns out that these were using different criteria, but it turns out that the prevalence of malnutrition is strikingly high. Depending on where you are in the world, about 1 in 3 hospitalized patients may experience malnutrition, up to half of people in long-term care, and maybe about 20% or so of people in home care. In older populations, this is an even bigger issue. People over 65 in some settings have been suggested that maybe 2/3 of them could have some degree of malnourished if they're in the hospital setting. And it's recognized that for people who are in the hospital, many people will actually become malnourished during their stay in the hospital if they have a long hospital stay. Unfortunately, this is across every aspect of the hospital, pretty much no matter what setting you work in. So I work in gastroenterology, which typically would fall under general internal medicine, and we collaborate a lot with surgeons. And from this study, there were about a third of the people who were at risk for malnutrition on those. But you can see, in an infectious disease service, it may go up to get close to 50%. Turns out that being malnourished in the hospital is a bad thing. Here's one study, and then I'm going to show you a bit more about the association between malnutrition in the hospital and your risk of 30-day hospital mortality. This was an interesting study because they really just looked at how much food people had eaten on a given day, and then associated that with their risk of 30-day mortality. And if somebody ate about half of the food that they were served that day, they had a mortality that was pretty similar to people who had eaten everything. But if they only ate about a quarter of it, you can see about a 3-fold increased risk in 30-day mortality. And if they had eaten nothing, it went up to 6-fold risk. And one that I think is important to really think about is this group that was not allowed to eat. So we know that many patients in the hospital are made nil per os, or nothing to eat, for the purpose of either you think you're helping their disease process or for diagnostic testing. And I'm not saying that making them nil per os is actually what causes the 30-day mortality here, but it is a marker of people who are certainly at high risk for mortality. So in general, you can say that malnourished patients have about up to a 5-fold increased risk of mortality when they're hospitalized. They're certainly at increased risk for readmission. It's been shown that they have longer lengths of stay. They're twice as likely to develop complications that are preventable, so things like pressure ulcers, or surgical infections, and these are the people who are falling. So what can we do about this? There has been a fair amount of work done to see whether you can intervene on this. And this was some work that I was part of that was led by my colleague Shazia Sadiq, where systematically reviewed the literature on interventions to try and reduce mortality particularly for hospitalized patients. And there were about 11 randomized trials that were identified that had looked at mortality, 9 that had looked at length of stay, and 7 on readmissions. What you see is that specialized dietary interventions tended to not really have a whole lot of effect on length of stay of readmissions. But amazingly, it was just, these specialized dietary interventions were associated with about a 20% reduction in mortality. So this is it's not a hopeless game. This is a space where being cognizant of the people who are in need of specialized dietary recommendations, and some of this is as simple as protein supplementation, can have a real impact on outcomes that are of the most importance. So up till now, I focused really mostly sort of on like malnutrition and access to nutrition. It's also important to think about nutrition quality. I live in the United States, and here the nutrition quality, even though we have an abundance of food available for most people, the quality of that food is not that necessarily healthy. These are now close to a decade-old data, but it was reported that between 2013 and 2016, about a third of U.S. adults consumed fast food on any given day. Which brings us to this topic of processed foods. So these are foods that have undergone processing in order to improve their texture, taste, or shelf life. Typically, these foods will have a higher content of fat and added sugar and salt, and a lower content of fiber and vitamins. But the real focus has been on ultra-processed foods. And you can think of these as foods that contain little or no whole food. These are chips, hot dogs, chicken nuggets, cereal, soda, etc. And it turns out they actually contribute a huge proportion of the daily energy intake, at least in North America and Europe. So in the US and Canada, it's estimated these represent anywhere from 25 to 50% of our energy intake. A way to classify these foods is to use something called the NOVA scale, where group 1 foods are unprocessed or minimally processed foods. Group 2 are processed culinary ingredients. So you can think of butter, salt, sugar, and oils. Group 3 are processed foods, but not ultra-processed foods. So a nice example of these would be canned or bottled fruits, vegetables, and meats. Bread falls into this category, as do most cheeses would fall in here. And you usually get to group 3 by sort of combining group 1 and 2. And then group 4 are really where most of the focus is today, are ultra-processed foods. And as I mentioned, these are foods that really contain no appreciable whole food. They're largely food derivatives. And I think it's easy to say that, a can of soda would be the ultimate example of an ultra-processed food. Well, here's some data. These are from Sweden, but similar to many other parts of the world. And if you look over time from 1960 to 2010, you saw this just massive uptake in the consumption of ultra-processed food. So 142% increase over the course of half a century. These are some data from the United States. So the bar graph in the middle shows you the percent of calories from ultra-processed foods that people in the United States were consuming. You can see that the mode is somewhere around 54% of their calories in this study. And then it's a little hard to follow this figure, but on the y-axis on the left is the distribution of your percent of calories from ultra-processed foods. And on the right is the difference in your cardiovascular risk score. And so the line basically shows you that the more ultra-processed foods that you were taking in, the worse your cardiovascular heart risk was. It's probably not that surprising because we know that the dietary patterns that are associated with consumption of less processed foods, the Mediterranean diet being the classic, although increasingly we're just thinking of this as a plant-based diet, has been associated with improvement in many different outcomes. This is a somewhat old now systematic review and meta-analysis that looked at mortality, and I always think that mortality trumps all the other outcomes. But you can see pooling together these studies with relatively little heterogeneity, that those people who tended to follow a more Mediterranean style diet, so lots of consumption of fruits and vegetables and legumes, some complex carbohydrates, moderate consumption of fish, but the absence of all of these refined sugars and red meats for the most part at low levels. Here you see, about a 10%, 8 to 10% reduction in all-cause mortality. So that's consumption of these foods as a whole. I'm going to shift a little bit into gastrointestinal diseases, which is where I work with a particular focus on inflammatory bowel diseases. So there's two main forms of inflammatory bowel disease. One is called Crohn's disease. The other is called ulcerative colitis. These are chronic inflammatory disorders of the intestines. They tend to wax and wane. These are immune-mediated diseases. So you can think of this in the same categories as things like rheumatoid arthritis, psoriasis, asthma. They're part of this global epidemic of immune-mediated diseases. These are some data that we published just this past year, looking at how prevalent this has become. So today in the United States, almost 1% of the population has inflammatory bowel disease. So it's 0.7% of the US population. It's a lifelong disease. So you see the prevalence just continues to rise as people get older until about 80 plus, where it starts to fall off a little bit, suggesting maybe there's a slight increase in mortality for these people, particularly at older age. That's not the point of this. Is to say this is a common set of diseases. We used to think of these as rare diseases, but almost 1% of the US population now. Interestingly, there's been some research, a number of studies that have looked at this relationship between ultra-processed food and new diagnosis with these inflammatory bowel diseases. And fairly, even though we think of these two diseases as being very similar, and really covering a spectrum, even though the clinical manifestations are slightly different, the relationship between ultra-processed foods and inflammatory bowel disease has been quite specific to Crohn's disease and not ulcerative colitis. I don't have an explanation for you for why that is, but Crohn's disease is a more transmural disease. It also can affect any part of the intestines. Transmural meaning it's not just the lining of the intestines, where ulcerative colitis affects only the lining of the large intestine. But this association with increased risk of developing Crohn's disease based on people who had eaten ultra-processed diets over a long period of time. And in this study, they measured their dietary intake well before people developed their inflammatory bowel disease, has been reproducibly seen now for Crohn's disease in multiple studies. But one of the things about this that I think is particularly interesting is it's maybe flipping some of what we thought about before on its head. So on the left of this slide is a summary of a previous systematic review of the literature, which really had pointed to the idea that increased consumption of polyunsaturated fats, omega-6 fatty acids, and meats in particular as a source of that had been associated with this increased risk of Crohn's disease and ulcerative colitis, and more consumption of fruits and vegetables and fiber was protective. On the right-hand side, I'm showing you the results of an analysis from the PURE cohort. So this is this multinational cohort. And what you see, the point of this is that when they included consumption of ultra-processed foods in the regression model to sort of look at this association between fruits, vegetables, and meats with the risk of inflammatory bowel disease, it totally goes away, suggesting that maybe it's actually the ultra-processed foods, not necessarily the fruits and vegetables and meat consumption, but it's really the consumption of ultra-processed foods. And the more ultra-processed foods you're eating, you're probably eating more of these polyunsaturated fatty acids and meats and less fruits and vegetables. That brings us to the question of, well, why would ultra-processed foods be bad for you? I mentioned before, these typically have a high content of salt, sugar, and saturated fats. They're ultra palatable and calorie dense, and it's been shown in other research that if you give people access to ultra-processed foods versus processed foods, they will just continue to eat more of the ultra-processed foods and gain more weight. They have chemical additives that may disrupt the microbiome and metabolome, and I'll talk more about that in a few moments. There's some concern about, are you picking up xenobiotics from the packaging? And maybe it's just that you're replacing other foods that have health benefits. Maybe it's not that the ultra-processed food is bad, but you're not getting enough of these other foods. Although what I just showed you for Crohn's disease really doesn't support that last hypothesis. Well, let's talk about these chemical additives. These come in a variety, but they're mostly emulsifiers or thickeners. You can think of emulsifiers as compounds that are like detergents that stabilize these immiscible liquids. They bring them together. This is how, I don't know if you, in Qatar, you probably don't have mayonnaise, but this is how mayonnaise works in the United States. And then there are thickeners which increase the viscosity of a liquid without really changing its other properties. There are lots of these that are routinely used. I've listed some of these here. In the United States, most of these fall under a category generally regarded as safe, meaning you don't have to do a whole lot to prove that you don't have to do a lot to prove the safety of these. You can just sort of use them in the culinary industry. Here's some of the places that you find these. So carboxymethylcellulose is used, for example, to replace gluten, fat, and starch. And I'm going to talk about it more in a moment. Polysorbate 80 found in the ice cream that I ate last night for dessert. If you chew a lot of gum, it's in there. Carrageenan's in a lot of dairy-based desserts and frozen meals and processed meats. Maltodextrin is actually in some of the sweeteners. It's found in lots of soft drinks and candy. Soy lecithin feels like it's in almost everything. You see salad dressings, mayonnaise, and xanthan gum, again, found in lots and lots of things, particularly salad dressings, baked goods, etc. This was a study that a former trainee of ours did that just looked at if you had children with Crohn's disease, like how many exposures were they having per day of some of these? And you can see that xanthan gum and maltodextrin and soy lecithin, these were the most common ones that people were being exposed to, really about at least one food per day that they were consuming that had this on the label. A little bit less for carrageenan. And then the other ones, which have actually gotten much more attention, polysorbate 80, carboxymethylcellulose, titanium dioxide, much less commonly consumed. But I'm going to focus for a moment on polysorbate 80 and carboxymethylcellulose because this is where some of the research has been done. So at an animal model level, if you take carboxymethylcellulose or polysorbate 80 and add it to the drinking water of mice, what you see is that the mucus layer gets thinned out. So that's on these slides, this is the epithelium, the green is the mucus layer, and these little orangish dots are bacteria. And so with adding carboxymethylcellulose or polysorbate 80 to the drinking water, you can see that the mucus layer is thinned and there are more bacteria that are encroaching on the lining of the epithelium. And that's demonstrated here in this graph to see the mathematical difference. It's thought that this is in part due to a change in the composition of the microbiome so that you wind up with bacteria that are, in essence, able to consume the mucus layer. The importance of this conceptually is maybe not how it happens, but the fact that if you take mice that are predisposed to developing colitis, so this is an animal model of these inflammatory bowel diseases where I work, and you put carboxymethylcellulose or polysorbate 80 in their drinking water, they're even more likely to go on to develop colitis. So 3/4 or so by 60 days had developed colitis as opposed to about 40% in the genetically predisposed mice. Because of this, we were interested in asking, what happens when humans consume these? And so we designed a study that we referred to as FRESH, Functional Research on Emulsifiers in Humans. And this was a controlled feeding experiment where we had 16 healthy volunteers. We put them on an additive-free diet. So everything was made fresh ingredients, no additives, and then randomly assigned them to consume either that same additive-free diet or that additive-free diet with a lot of carboxymethylcellulose, so 15 grams per day. This was certainly a high dose of this, and we mixed it into some sorbet and brownies so that people wouldn't know whether or not they were getting the carboxymethylcellulose. I want to point out, we did this in a domiciled setting, so we had complete control of everything that people were eating over the course of this time period. And here are probably the main takeaways from this. One of the interesting things was that actually their fecal microbiome, so the bacteria that were living in their gut, changed by being on the carboxymethylcellulose relative to the controls. You can't appreciate it from this figure. It doesn't really take away the between subject variability, but people tended to move in a similar direction, whether or not they were on the carboxymethylcellulose. It also changed the small molecules that we could measure within their feces. So particularly, if they were getting carboxymethylcellulose, there was a reduction in many of the amino acids that we were able to measure in their feces by having them consuming the high dose of carboxymethylcellulose. One other thing that we did in this study, and it was actually one of the main goals of it, was could you actually measure carboxymethylcellulose in their feces? And in fact, you can see we could very clearly measure it using nuclear magnetic resonance. You might ask, well, why is this important? I showed you a slide a few back about the work that my former trainee Dale Lee had done, just trying to understand how often people had been exposed to these additives, emulsifiers, etc. When people market food, like, you don't have to say how much of these ingredients are included. You just have to put on the label that they're there. And we don't really have a great way of knowing whether people are consuming these. So there is a need in the field to develop biomarkers that would be able to be used to assess the amount of exposure people were getting. Now, we did this in feces because carboxymethylcellulose is minimally, if at all, absorbed, not an ideal biomarker. You would love to have something in blood or urine, but it just showing that it is possible to measure these and think about ways to be able to measure these on a broader scale for large epidemiologic studies. So in the next phase, I want to move from additives to dietary patterns. And so we've spent some time thinking about, why is a nutrient-dense diet healthy? And what are the features of a modern Western diet that are unhealthy? And to try and address this, we recently finished, although we haven't published this yet, so I'm going to show you a tiny bit of unpublished data. We wanted to explore the impact of an ultra-processed food-based diet compared to a Mediterranean-style diet on human physiology, the microbiome, and the metabolome. So this is another one of these controlled feeding experiments. So here we took about 15 healthy volunteers, kept them in a controlled setting for 11 days. And we did this as a crossover design where for 4 days, they were either on this whole food Mediterranean diet or what we referred to as a convenience diet with ultra processed foods. Then there was a 3-day washout, and then they went on the other diet for 4 days. And they were able to take in as many calories as they want, but however many calories they took in the first 4 days, they had to take in the same amount of calories in the last 4 days. So here were the diets. The lead-in and the washout diets were mostly NOVA level 2 and 3 foods. So as a reminder, these are sort of like, canned peaches and oils and stuff like that. The minimally processed Mediterranean diet was all NOVA level 1 and 2 foods. And the ultra-processed convenience diet was essentially 100% ultra-processed NOVA level 4 foods. And we did our best to make the convenience diet be the sort of analog to the Mediterranean diet. And let me show you some examples. So if on the minimally processed diet, you were getting baked fish with an olive oil drizzle, I don't know if this resonates in Qatar, but you got frozen fish sticks if you were on the ultra-processed diet. If you were getting sauteed potatoes in the minimally processed, you were getting tater tots on the ultra-processed. if you were getting spinach salad with a dressing on the minimally processed, you were getting cream spinach from a can on the ultra-processed diet. So I mentioned we did this in 15 people, about 60% women, mean age was 34. This is a fairly mixed population for the US, so 60% white, 20% black, 13% other, and actually a very not obese population for the US with a BMI of around 25. I just want to show you that these two diets, the convenience and Mediterranean, were actually, even though they were designed to be sort of analogous, they were very similar in terms of what their presumed health benefit. So this is the healthy eating index score, where the higher is better. And you can see our Mediterranean diet was close to 90 versus a score of about 50. Typical diet in the US is probably in the sort of 55 to 60 range. So this was a little less healthy maybe than a typical US diet, but not that far off. This is a dietary inflammatory index marker, and you can see that the presumed inflammatory component of the diet was much more favorable in the Mediterranean. Nonetheless, people were getting relatively similar amounts of calories from their fats, carbohydrates, and protein, but certainly getting much more fiber on the Mediterranean diet, and much less sodium on the Mediterranean diet. You might say, well, this was really short. You only had these people on these for a handful of days, 4 days. But this was enough time that you could see physiologic changes. So I'm just showing you change in weight. And, so with the ultra-processed diet, zero, almost no change, but a change with the, if it was your second diet, about 0.7 kilograms. And you could see there was enough that you could see a difference in weight change. Now, most of that was probably related to sodium, but just to say the diets were different enough that you could measure a physiologic effect. So here, I'm going to show you, these are unpublished, but will be presented in other forums soon. So this was the impact on the urine metabolome. So we took people's urine samples at the end of the 3 dietary periods, the first dietary period, the washout, and their second dietary period. And here they're colored by which diet they were on. And you can see if you measure the small molecules, so these are things that you're absorbing, they're going through your blood and being cleared by your kidneys. Like there is complete separation. Like, so you are being on these different diets, you're getting a very different exposure of small molecules, which can potentially have health impacts in the long term based on which of these diets you're on. And on the right-hand side of this screen, these arrows point to, what were the small molecules that were driving some of these spread out. One of these, you can see trimethylamine pointing to the north. So trimethylamine is found in fish. So this is the reason that you'll see that both the convenience diet and the Mediterranean diet are sort of in one direction, and then the washout was in the other. And this is because the washout diet was the only one that didn't have any fish in it. So that's just like one example for you. All right, so from these sort of controlled feeding studies, I think we can say that individual dietary additives can certainly influence the microbiome and the metabolome of healthy adults. Probably doesn't totally take away the between subject difference. And for sure, these dietary patterns impact our urinary and our fecal metabolome in healthy adults. But if we want to move from these small ultra-controlled experiments to patients, where does that take us? And so I think in the world that I live in, there's lots of opportunity for nutrition as a therapy for gastrointestinal and liver diseases. Fatty liver disease and cirrhosis, super common in the US, and the #1 therapy is 5 to 10% weight loss to fix your fatty liver disease. For people who have cirrhosis and sarcopenia, we should really be thinking about them getting late night snacks. And I don't have time to talk about all of these, but for irritable bowel syndrome, the #1 reason that people see a gastroenterologist in the United States, diet has become the primary therapy, and using a low FODMAP diet, low in fermentable foods, is the #1 therapy today for these. And then I live in the space of these immune-mediated diseases. So eosinophilic esophagitis, we know that various elimination diets can be effective, although hard to follow. Celiac disease, obviously, a gluten-free diet is the primary. And then I've spent time working on Crohn's disease, one of these inflammatory bowel diseases. And for nutrition as therapy, we have a few basic strategies. We can add things, we can take things out, or we can modify it. I'm going to show you historically that if you replace regular food with enteral formulas, so think of Ensure, Boost, these sort of formulas that you can drink as meal replacement formulas, that if you use this sort of exclusive approach where you provide 90% of more calories from formula, hugely effective for people with Crohn's disease. The problem is it's just not a diet you can follow long term, but it doesn't really matter whether what the protein structure is. But if you replace people's regular food with these formulas, about 70% will go into remission, which is way higher than you would expect with placebo. But obviously you can't do a placebo-controlled diet of formula. And this has actually led to recent guidelines from Europe suggesting that using this as a nutritional therapy could be a first-line therapy for people with Crohn's disease. And the problem is we just have to find what the maintenance therapy for those people would be. But how about whole food diets? Because the people don't want to be on these formulas forever. This was a systematic review that's looked at various whole food diets, and I'm going to tell you about just a couple of these real quickly. One is this question of a Mediterranean diet that we've talked about versus a specific carbohydrate diet. So this is a trial that we completed recently where we compared these two diets. For those of you not familiar with specific carbohydrate diet, this is basically you're taking out all grains, dairy other than some hard cheeses, and sweeteners other than honey. And you're focusing mostly on fruits and vegetables and some unprocessed meats. And so in this trial where the primary outcome was measured at 6 weeks, even though patients believed that this ultra-restrictive specific carbohydrate diet would be the more beneficial, just following a Mediterranean diet worked just as well. Unfortunately, even though fecal markers of inflammation got better, very few of our people showed benefit of CRP in their blood, but about 45% of people had symptomatic resolution. And it didn't really matter how much inflammation. For the sake of time, I'm going to skip to one other one. This is one that's gotten a lot of press recently. This is Crohn's disease exclusion diet, which is based on consuming chicken, eggs, potatoes that have been cooked and cooled so the starch will be more resistant, and then fruits and bananas. And here was a trial where this was using this, and half your calories from formula went head to head against getting all your calories from formula for 6 weeks. And then both of them reduced their calories from formula to 25% for the second 6 weeks. And you can see that following this very targeted diet based on these few foods did much better than going back to your regular diet for 75% of your calories. You might wonder, was it the formula or was it the actual foods? Probably a little bit of both, because there was a group of these randomized trial where they did it without the formula versus with the formula. And if you were drinking half your calories from formula, you did seem to do a bit better than with the food alone. So I just want to, at the end here, come back to malnutrition in patients with inflammatory bowel disease to bring this full circle. We know that malnutrition is really common in hospitalized patients with inflammatory bowel disease. At least 3 to 4 times more common. It's often exacerbated by us not allowing them to eat in the hospital, and it's associated with increased in-hospital mortality. We looked recently at what about those people who are in the hospital and are going to need surgery, and what if we put them on this same formula-based diet as opposed to regular food to get them ready for surgery? And interestingly, if you pull together these large collection of observational studies, and unfortunately, these are not randomized trials, but you can see that by being on exclusive enteral nutrition for a period of time prior to your semi-elective surgery, it was associated with reduction in intra-abdominal septic complications and reduction in skin and wound infections. And actually, the European guidelines have now pointed to this using exclusive enteral nutrition, so a formula that you can drink, but for all your calories leading up to surgery may be used as a bridge in high-risk patients to reduce complications. So on that note, and hopefully coming full circle, I'll just conclude by saying that malnutrition is clearly a predictor of poor outcomes. This is both from undernutrition and from poor nutrition. Omics, so microbiomics, metabolomics, et cetera, has made studying nutrition fashionable again, but it hasn't completely solved the mechanistic questions. I don't think we know for sure really how food is driving health. But it's really important that we think about nutrition as both a primary or a complementary therapy because it's applicable to almost every domain of medicine and health. And most certainly, we need more randomized controlled trials to guide evidence-based dietary recommendations. And I will conclude just with some acknowledgments. Some of what I've shown you was our own research, and the work that I've done has only been possible because I've had so many wonderful people to collaborate with over the years, particularly here at Penn. Gary Wu and Charlene Comfer and Rick Bushman and Bob Baldessano and Hongzhi Li, Kyle Bittinger, and others have been incredibly close collaborators on the dietary front. And then you see many other people from around the country who have been wonderful to collaborate with. So I will stop there and stop sharing, and hopefully we have time for a few questions.
Okay, so thank you, Dr. Lewis, for that wonderful presentation. Really, really good information that you've given us. We've had some questions which have been coming in, and I think we can just go ahead with those if you're okay with that.
Sure.
So Dr. Lewis, of course, you've been practicing for many, many years, and what are your thoughts on, what are the kind of challenges you face, while encouraging patients to adhere to a Mediterranean style diet, to stay away from ultra processed food? What are your words of wisdom, that you can share with the healthcare professionals? Because this is one of the biggest challenge, that we face as healthcare professionals.
Yeah, so I think there's challenges on many different levels, and some of these are intuitively obvious. One is that ultra-processed foods taste really good. I told you I had ice cream for dessert last night.
Absolutely.
But on the other hand, I had a really small serving of ice cream for dessert. So I think portion control is a really big thing to think about. And you don't need to eat the entire bag of chips. You can get away, if a few of them will satisfy your craving, some of this is amounts, probably not just all or none. I think it's very difficult to think about becoming truly saying, I'm only going to have like minimally processed foods for my life. There are people who do this, but in society, that's really difficult. It would, like, to go out with friends for a meal would become incredibly difficult, but you can be selective. In the US, I think there was a period of time during the peak of the pandemic where you saw people having changes in dietary patterns. You had some people who were doing more cooking at home than they had ever done. And that was an opportunity for people to experiment with actually cooking from fresh ingredients, although people who hadn't cooked a lot probably still wound up cooking mostly ultra-processed foods. My approach to people is to say, look, you have to think about nutrition in a couple of different ways. Am I just trying to improve my overall health? Or for, like in my practice, where almost everybody has one of these chronic diseases, Are you trying to use this as primary therapy? If you're trying to use it as primary therapy, you may have to be more rigorous in your adherence than if you're just trying to improve your overall health. And so if you can, if you're just trying to improve your overall health, if you can manage to focus on starting with 1 meal a day, I'm going to do this. And then a month from now, I'm going to go to 2 meals a day. I'm going to be really good about this. And then maybe in the next month, I'm going to take away my between meal snacks that are less healthy, and I'm going to replace it with a handful of nuts instead of potato chips. You'll already have been making a great stride forward, but you don't have to beat yourself up because it's my mother's birthday and we're going to have a celebration and there's going to be a lot of things that probably wouldn't be there. So it's fine. For one day, I cheated a little bit, not the end of the world.
Sure. Okay, great. Thank you. So just talking about, food as therapy that you just alluded to. So what type of, food is good for patients with inflammatory bowel disease, and what kind of messages, can we give to the healthcare teams, to educate patients who have inflammatory bowel disease?
So specifically for people with inflammatory bowel disease, I think one of the biggest things that we've learned through these last couple of clinical trials, and I maybe should have spent more time on them, but with you, is historically we would tell everybody, avoid lots of fruits and vegetables and fiber, it's just going to upset your symptoms. But these trials have shown that even symptomatic people, they can tolerate fruits and vegetables. Some of it is how they're prepared. So we're increasingly thinking more about texture than we are about, oh, there's too much fiber in that, you can't have that. So while I may not tell people to race out and have a giant salad for lunch, having some cooked spinach is probably okay. And so I think we have to think about preparing these fruits and vegetables in a way that people can tolerate them. But in our trial with Mediterranean diet and specific carbohydrate diet, both of the groups increased their amount of fiber intake. And yet 50% of the people said they had almost complete resolution of their symptoms with doing this. So that's been an important part of the message. I really emphasize to people that to the extent that you can get ultra processed foods out of your diet, there's no doubt it's hard to come up with what health benefit you could get from drinking a can of soda. There's probably no health benefit there. So I try and, for most people, start on the little smaller end of that. The other end of this, we deal with people with chronic gastrointestinal disorders are always convinced that what they're eating is the source of their problem. And so you risk people actually showing up with psychopathology, if you will. And I say this in a gentle way. There's this condition called ARFID, avoidant restrictive food intake disorder. And we're becoming very conscious in our field of not being so overly restricted that we spawn the beginning of people having avoidant restrictive food intake disorder.
Right. Okay. Okay, thank you so much. Just another question while we're talking about, food, about coffee. So maybe you can touch base on, if coffee, affects patients with IBD, and, how in general, does it affect our microbiota at all?
Yeah, what a wonderful question. It's actually still morning in Philadelphia. I know it's afternoon where you are. I think coffee is a fascinating compound. It's not a focus of my particular research, but I'm appreciative of all the work that's been done. It's one of the few things that I think it's hard to find any negative impact that it has on people other than disrupting your sleep. And from a gastrointestinal point of view, there's been so many studies that have shown improved, at least measures of liver enzymes in people who consume a bit more coffee. And for the most part, coffee is associated with longevity. It's very hard to find a negative study about coffee. There was as an epidemiologist, years ago, there was these studies that had suggested that coffee may have been contributing to pancreatic cancer. I think this is a study that is used in almost like every epidemiology course of how selection bias can get you to the wrong answer. It stimulated an entire field of people proving that that was wrong. But I would say you should have no concerns about drinking coffee unless caffeine is a problem for you. And the last thing I would say about it is interesting. Most of the studies have shown it's not caffeine. It's got to be the other things, the other sort of volatile compounds in coffee, maybe,
Okay.
because caffeinated and decaffeinated have the same health benefits.
Right. Okay. Thank you. So Dr. Lewis, just to talk a little bit about, fruits and vegetables, of course, we know the whole foods, the whole fruits, vegetables, they're good for us, the natural ones. What about the dried fruit and vegetables? So of course, now you even get things like kale chips and, every other vegetable chips that is available. What are your thoughts on that?
Yeah, that's a great question. I had some dried apricots for breakfast this morning. I actually don't know the answer. Some of them have actually a lot of calories in them,
Right.
so you should be conscious of that. I
Mhm.
suspect it's not as good as having the real undried,
Right.
unprocessed fruit, but
Yes.
probably not as bad as the can of soda. So
Right.
I bet you it's somewhere in between. I don't actually know of primary research that has
Yes.
looked at it.
Sure. So just to have a balanced approach, thinking really about, okay, if I'm making these choices, what is maybe the better choice for our health?
Yeah, we have some dried banana chips in our house right now, and I was looking at the package recently. I mean,
Right.
there's coconut oil and stuff that was used in the process of
Sure.
drying them out.
Yes.
Still probably better than taking a cookie out of the bag.
Yes. Sure. Okay. Great. Thank you. And just a related question again. Of course, they're using a lot of fertilizer now and other chemicals, in our fruits and vegetables, and preservatives, in the products that we see in the market. So, any thoughts on, the kind of effects that they may have on our health in general, I guess?
Yeah, I wish I knew the answer. We've talked about this over and over.
Mhm.
I don't know about in where you are.
Qatar.
In the US,
Right.
there's this giant market for organic
Yes.
organic
Sure.
produce,
Yeah.
essentially grown without all these fertilizers and, well, not necessarily the fertilizers, but pesticides and the
Right.
like. You pay a lot more for the organic.
Yes.
It's unclear to me that there is a specific health benefit from it, but I don't
Right.
know that this is going to take gigantic studies, very hard to sort out because nobody is unexposed to the non-organic. Like if you go get a meal from a restaurant, highly unlikely that they were using organically grown vegetables, because it's going to cost them so much more to get it.
Mhm.
Um, I will say, for whatever it's worth, in my household, we mostly do not buy organic because we haven't found the evidence that it makes a difference.
Sure.
I wish if somebody in the audience probably knows the answer and they're cringing at my answer to this question, but I'm being honest, like I'm just not aware that it's been proven that one is better
Yes.
than the other.
Sure, and I would agree with you. We are not sure if there's any additional nutritional benefit, by eating organic food products only.
I think one thing to think about in the practical part of this, though, is, you know, trying to have a more plant-based diet that is less processed is more expensive for most
Right,
people. So we need to not raise the bar even higher, like to say
right,
it has to be organic. Like, look, I
sure.
guarantee you it's better to have a plant-based diet that's from not organic than to have a less plant-based diet.
Mhm. Okay, so just coming back to inflammatory bowel disease, and since that's your area of focus, we have a few more questions if you're okay.
Yeah,
We
sure.
can
Yeah.
try and answer those. What about milk and milk products, for patients with inflammatory bowel disease, and also what about nuts, seeds, etc.?
Yep. So great questions. Um, I was part of a panel from the International Organization for the Study of Inflammatory Bowel Disease, where we said, all right, let's just look at the literature and just try and come up with some practical recommendations for people. What was interesting, we could come up with practical recommendations on almost every area. And when we got to dairy products, we couldn't come to agreement amongst the group.
Okay.
There's the component of obviously people who have lactose intolerance, and that's easy. Either have lactate-free milk or use a lactase supplement.
Yes.
Um, Part of the challenge was what defined a dairy product. So yogurt is very different from ice cream, but they would
Right.
both be considered a dairy
Yeah.
product.
Yes.
And I think that was a lot of the reason we had a hard time coming to an agreement about this. My general guidance to people is, look, you need to get some calcium and vitamin D and things of that nature. And in the US, milk is one of the big ways that people get calcium and vitamin D. On the other hand, you know, there are other ways to get this. And if you have intolerance to milk, we encourage people to avoid it.
Okay.
The seed question mostly came from historical data about diverticulitis. So this is another form of inflammation that people get of their
Right.
bowel. Totally debunked. There's now been studies done showing it is not, you're no more likely to get a flare of diverticulitis if you're consuming seeds or nuts and nuts. And nuts are obviously a great source of nutrition that's healthier than most of the other things.
Mhm. Okay, great. Thank you. And just a question, since you've mentioned diverticulitis, so is there any specific diet for, and basically for diverticulitis?
Yeah, there's really not. The most important thing is telling people they don't need to like completely avoid seeds and nuts. Obviously, if you have a stricture
Right.
from long-standing diverticulitis, that's a different story, and you need to really be thinking about this, how fibrous is my food? But in general, if you're trying to prevent your next episode of diverticulitis, you don't, I remember speaking to somebody, like, oh, I can't have a tomato. It's got these little seeds in it. I can assure you, if you do a colonoscopy with people with diverticulosis, you'll see these little diverticuli all full of stool, but they don't have diverticulitis. That little seed is not the problem.
Okay. Okay. Thank you. So I think I'll just end with these last couple of questions. So what are your thoughts about probiotics, and IBD? Do they help? Which kind would help? And then, how about smoking and drinking tea?
Yeah, great questions. Probiotics on the IBD part of this, I will say for most people, I don't think they're particularly useful. I view them, for most people, these are like tourists. They go in,
Okay.
they take a look around, and they leave. They don't really
Right.
set up shop and do work.
Okay.
They're, on the other hand, for people who've had their entire colon removed, had their small bowel fashioned into a like pseudo-rectum for them, it's called a J-pouch operation. There are some clinical trial data saying that probiotics may be beneficial in preventing inflammation there. And so in that setting, sometimes I will recommend probiotics. The other question, you said one
About
last thing.
tea and smoking.
Tea and smoking. So smoking, I don't know about tea, but I don't think it's the same as coffee. And there are
Okay.
so many different teas that I don't know
Right.
if anybody will ever sort out the tea
Yes.
question. The smoking is, in the space where I work of inflammatory bowel disease, is one of the most fascinating environmental exposures because it increases your risk of Crohn's disease and it protects you from getting ulcerative colitis. There's only
Mhm.
a handful of diseases that I'm aware of that smoking is protective. Ulcerative colitis, Parkinson's disease, very, very few of these. No one has been able to figure out why this is. But I can
Sure.
tell you, I have, you know, the rare patient who has ulcerative colitis and cannot quit smoking because every time they quit smoking, their disease relapses.
Okay.
And like I have one person, like we have our deal, you get 3 cigarettes a day.
Okay.
And he's negotiated this with his wife, and that's how he stays completely in remission. But
Okay.
it's a mystery that has failed to be answered
to date.
to date. Yeah.
So,
Yeah.
okay, so I think a great round of question and answers also. So Dr. Lewis, very, very grateful to you for taking the time out. I think we had great questions from the audience. Of course, there's a lot of interest. Again, thank you so much. Gratitude to you. We would like to thank all our participants.